A man named Gerald, 71 years old, walked into his annual physical last March, feeling better than he had in years. No chest pain, no shortness of breath, blood pressure, controlled, blood sugar, stable. He'd lost 15 pounds over the previous year, was walking 2 miles every morning. Gerald was healthy. His doctor ran the usual battery of tests, routine stuff. "Just checking," she said. "Better safe than sorry." One of those tests came back with an elevated number, not dramatically elevated, slightly, borderline, the kind of number that in another era, nobody would have blinked at. But once it was in the chart, the machine started turning. Follow-up blood draw, then a biopsy, then a consultation with a specialist, then a surgery that was supposed to be minor. 8 months later, Gerald wears adult diapers. He can't walk his 2 miles anymore because the nerve damage from the surgery left him with chronic pain in his lower body. His wife says he doesn't leave the house much. Gerald didn't have a disease that was going to kill him. He had a test result, and that test result destroyed his life. Now look, I'm not telling you Gerald's story to scare you away from your doctor. I'm telling it because what happened to Gerald is not rare. It's not a fluke. It is a documented, studied, peer-reviewed medical phenomenon, and it is happening to seniors across this country every single week. The U.S. government's own independent medical panel, the Preventive Services Task Force, has reviewed the evidence on the most common screening tests ordered for seniors. And for several of them, they've said clearly, publicly, in plain language, these tests cause more harm than good. Not might cause, do cause. Today, I'm going to walk you through 5 of them. But I'm not just going to list them and move on. I'm going to show you the mechanism. How a single routine test triggers a chain reaction of procedures, each one more invasive than the last, that ends with real people living Gerald's outcome. And toward the end, I'm going to give you something you can actually use. 4 tests you should absolutely never skip. Plus 3 questions, written on a card you can bring to your next appointment, that could protect you from more harm than any screening ever will. If you believe seniors deserve the full truth about what's being done to their bodies, tell me in the comments. Say full truth. Because the billing system does not want this video getting views. This is Senior Health Blog, and the truth starts now. Before I get into specific tests, and we're getting there, I promise, I need to walk you through a concept that changes everything. Once you understand this, every test I'm about to discuss is going to make complete sense. And honestly, you'll probably start seeing it everywhere in your own medical history. It's called the diagnostic cascade. And here's how it works. You go in for a checkup, feeling fine, no complaints. Your doctor orders a screening test, standard stuff. Preventive care, they call it. The test finds something, a shadow, a spot, a number that's slightly off. Now here's what nobody explains in that moment. That finding might be absolutely nothing. Benign. A normal variant. Something your body has been carrying around for years, maybe decades, without it ever causing you a single problem. But once it shows up on a scan, once it's printed on a lab result, once it's typed into your medical record, nobody can walk away from it. Not the doctor, not you, not the system. Because the system is designed to do one thing when it finds something: pursue it. Investigate. Intervene. Your doctor orders a follow-up test. The follow-up shows something borderline. Now you need a specialist. The specialist recommends a biopsy. The biopsy comes back inconclusive or atypical. Now there's a conversation about surgery or radiation or medication with side effects that change your daily life. Each step in this chain has its own risks: bleeding, infection, nerve damage, anesthesia complications, psychological damage. The anxiety alone can be devastating. And at the end of that chain, after the procedures and the recovery and the bills and the sleepless nights, the specialist sometimes says, "Looks fine, nothing to worry about. See you in 6 months." You just went through hell for a finding that meant nothing. That is the diagnostic cascade. And here's what makes it particularly dangerous for anyone over 65. When you're 40 and a test finds something slow-growing, you might have 40 years for it to become a problem. Investigating makes sense. The math works. When you're 72 or 78, the math flips. If a condition takes 15 years to become dangerous, and your remaining life expectancy is 10 or 12 years, that condition was never going to hurt you. It was going to coexist with you, quietly, harmlessly, until the end. But the surgery to remove it? The biopsy complications? The recovery time at 78 years old? Those can hurt you right now, this month, this year. And here's the part that'll make you uncomfortable. Doctors know this. Most of them, anyway. The good ones understand the math. But the system they work inside of doesn't reward restraint. It rewards action. Every scan ordered, every procedure performed, every referral made generates billing, whether you needed it or not. The legal system reinforces this. If a doctor misses something, they get sued. If a doctor treats something unnecessarily, nothing happens. No lawsuit, no disciplinary action, no consequence. So the incentive is always toward more tests, more procedures, more intervention. That doesn't make your doctor a bad person. Most of them genuinely care about you, but they're operating inside a machine that is not designed to protect you from unnecessary harm. You have to protect yourself. And that starts with knowing which tests trigger the cascade most often. Let me show you. The first one on this list is going to surprise a lot of people because it seems so harmless. The routine resting ECG, the EKG, that test where they stick electrodes on your chest, print out a little strip of paper, your doctor glances at it and says, "Looks good," or "Let's follow up." Now let me be very specific here, because I don't want anyone misunderstanding what I'm saying. If you walk into a doctor's office with chest pain, shortness of breath, heart palpitations, dizziness, get the ECG. Absolutely, that's a diagnostic test. That's different. That can save your life. What I'm talking about is the screening ECG, the one ordered at your annual physical when you feel perfectly fine. No symptoms, no complaints, just, let's check your heart while you're here. The U.S. Preventive Services Task Force looked at every available study and gave this test a grade D for asymptomatic adults at low to moderate cardiovascular risk. D means, and these are their words, recommend against. The harms outweigh the benefits. Published in JAMA, June 2018, peer-reviewed, not my opinion, the United States government telling doctors, do not routinely screen asymptomatic adults with this test. And here's the thing that most people don't know. The screening ECG does not reduce heart attacks. It does not reduce strokes. It does not reduce cardiovascular death. There is zero evidence, that running this test on someone who feels fine improves any health outcome. Okay, but what's the harm? It's just little stickers on your chest. And this is where the cascade kicks in. When you run a screening ECG on someone with no symptoms, you find things, irregular blips, slightly unusual patterns, a waveform that looks a little funny on the strip. Most of the time, these are benign, normal variants. Your heart is completely fine, but the machine printed something that doesn't look textbook perfect. And now it's in the chart. Your doctor can't ignore it. So they order a stress test. You walk on a treadmill while they monitor your heart. The stress test shows something borderline. Not clearly abnormal, not clearly normal, borderline. Now you need a cardiac catheterization. That's a tube, threaded through an artery in your groin or your wrist, all the way up into your heart. That is an invasive procedure, with real complications, bleeding, blood clots, arrhythmia, vessel damage. In rare cases, and I mean rare, but it happens, stroke or heart attack caused by the procedure itself. Think about that for a moment. A test that was supposed to check if your heart is okay triggered a chain of procedures, one of which can actually cause the heart attack it was looking for. That chain, stickers on the chest to a tube in the heart, is the diagnostic cascade in action, the USPSTF's own language for it. And at the end of that chain, the cardiologist often shrugs and says, "Heart looks fine, see you next year." Weeks of anxiety, multiple appointments, thousands of dollars, real physical risk, for a finding that was never a problem. Here's what actually protects your heart. And I mean actually, blood pressure management, cholesterol monitoring, family history assessment, smoking status, Diabetes screening. These factors predict cardiovascular events far more accurately than an ECG ever could. The USPSTF recommends using what's called the pooled cohort equations, a mathematical risk calculator, no electrodes, no cascade, better data. And that brings us to something even more concerning. Because the next test on this list, it's being sold to seniors at health fairs, wellness events, strip mall screening clinics, and the consequences are devastating. You've seen the ads, maybe at your church, maybe at a health fair, maybe a flyer in the mail. Know your stroke risk, free carotid screening. They put a probe on your neck. Check the arteries that feed your brain. 20 minutes. No needles. Sounds proactive, right? I mean, why wouldn't you want to know if your neck arteries are narrowing? Let me tell you why. The USPSTF gave this test a grade D for asymptomatic adults. First recommended against it in 2014, reaffirmed in 2021, published in JAMA. D. Again. Harms outweigh benefits. And the reasoning here is, honestly, it's hard to hear, but you need to hear it. The test itself, the ultrasound, works reasonably well. It can detect significant narrowing in your carotid arteries. That part's fine. The problem is what the system does with that information. When the ultrasound finds narrowing in someone who has no symptoms, no mini strokes, no dizziness, no visual changes, nothing, the treatment options get aggressive fast. Option 1. Carotid endarterectomy. That's a surgery where a vascular surgeon cuts open your neck, clamps the carotid artery, and physically scrapes the plaque out, with your brain's blood supply temporarily clamped. Option 2. Carotid artery stenting. A catheter threaded up from your groin into your neck, placing a metal scaffold inside the artery. Both procedures carry a real risk of causing the exact thing they're supposed to prevent. Stroke, during the surgery, on the table. Let me tell you about a woman. She's 74, retired school teacher from Ohio. No symptoms. Felt fine. Went to one of those health fair screenings because her friend talked her into it. It's free, why not? The ultrasound showed 60% narrowing in her right carotid artery. Dorothy had never had a stroke symptom in her life, but now she was terrified. Her primary care doctor referred her to a vascular surgeon. The surgeon recommended endarterectomy. Better safe than sorry, he said. Dorothy had the surgery. During the procedure, a small piece of plaque broke loose. It traveled to her brain. Dorothy had a stroke on the operating table. She survived, but she lost partial function in her left hand. A retired teacher who can't write anymore. Because of a screening test she didn't need, for a condition that wasn't causing her any problems. Now I want to be really careful here. I am not saying carotid surgery is never appropriate. For people who have had symptoms, a mini stroke, a TIA, sudden vision loss in one eye, carotid intervention can be life-saving. That's a different situation entirely. But for asymptomatic narrowing? In people who feel fine? The USPSTF found no evidence, none, that screening these people reduces stroke or improves survival. And here's the piece that really matters. Modern medical therapy, statins, blood pressure medications, blood thinners, lifestyle management, works just as well as surgery for asymptomatic carotid stenosis, without the surgical risk. So you've got a choice. Medical therapy that works, or surgery that carries a stroke risk for a condition that wasn't bothering you. The math isn't close. What actually prevents strokes? Blood pressure control. That's the biggest one. Cholesterol management. Smoking cessation. Blood sugar management if you're diabetic. Physical activity. These interventions reduce stroke risk more than any screening test, and they don't carry the risk of Dorothy's outcome. Now, I want to pause here for a second, because I know what some people might be thinking. Are you telling me to ignore my doctor? No, absolutely not. What I'm telling you is that more testing does not automatically mean better care. Sometimes it means the opposite, and you have every right to ask your doctor two things before any test is ordered. What changes in my treatment if this comes back abnormal? What are the risks of the next steps if something is found? 2 questions. That's it. Those 2 questions alone can stop the cascade before it starts. And this next test? The one at number 3 on this list? This one requires careful handling, because it has saved lives, but it's also harming people who didn't need it. Let me be very clear up front. I'm going to say this twice so nobody takes it out of context. Colonoscopy is a good test. It has saved lives. For adults between 45 and 75, colorectal cancer screening is strongly recommended. The USPSTF gives it a grade A for ages 50 to 75. I am not arguing with that. What I'm talking about is the routine screening colonoscopy in adults over 75 who have been previously screened and have a normal history, and especially in adults over 80. Because the risk-benefit equation, it shifts significantly. The USPSTF says that for adults 76 to 85 with prior normal screenings, the net benefit of continued screening is, and this is their word, small. For adults over 85, they recommend against it entirely. Here's why. And this part is important. The procedure itself becomes more dangerous as your body ages. A meta-analysis published in the International Journal of Surgery in 2024 looked at colonoscopy complications across age groups. Perforation rate in the general population, about 7.8 per 10,000. But for adults over 80, that rate more than doubled. And cardiovascular and pulmonary complications, from the sedation, from the physical stress, increased fourfold in patients over 75 compared to younger patients. A community-based study found even more alarming numbers. Perforation rates jumped 40 times higher in patients 75 and older compared to those under 75. 3 deaths occurred in that study, ages 75, 79, and 85. And perforation of the colon in an 80-year-old, that is not a minor complication. That's emergency surgery. ICU time, weeks of recovery if recovery happens at all. For many seniors, a major surgical complication at that age is the beginning of a decline they never recover from. But here's the other side of the equation, the one nobody talks about. Colorectal cancer typically takes 10 to 15 years to develop from a polyp into something dangerous. If you're 78 and you've been screened regularly throughout your life, the chance that a new polyp will grow fast enough to actually threaten your life? Very small. Meanwhile, the risks are right now. Today, the sedation, the bowel prep, which, if you've done it, you know what I'm talking about. That's stuff you drink the night before. For an older person with kidney problems, heart failure, or who takes blood thinners, that prep can cause dangerous blood pressure drops, severe dehydration, and electrolyte crashes that land people in the ER before the colonoscopy even happens. I spoke with a gastroenterologist last year who told me something that stuck with me. He said, and I'm paraphrasing, "I've been doing this for 25 years. I've seen the prep hospitalize more elderly patients than the cancers I'm looking for." Think about that. Let me tell you about the alternative that most people don't know exists. The FIT test, fecal immunochemical test. It's a simple stool test you do at home. Mail it in. No sedation, no prep, no perforation risk, no anesthesia. If it's positive, then you get the colonoscopy. Targeted. With a clear reason. If it's negative, you've screened for colorectal cancer without any of the procedural risk. So the next time your doctor says, you're due for a colonoscopy and you're over 75, ask this. Given my age and my screening history, would the FIT test be a reasonable first step? That one question could save you from a procedure you didn't need, and we're at the halfway point now. 3 tests down. But the last 2 on this list, honestly, they might be the most important, because the overdiagnosis rates are staggering. Before I get to the last 2, and I need you to stay with me for those, there's something else going on here that I think you should understand. It has to do with money. Not your money. Well, eventually, your money. But first, it's about how the system generates revenue. In the United States, screening tests are often covered at 0 cost to you. Preventive care. Free. You don't pay a copay. The insurance company pays. Sounds great, right? But here's what's happening behind the curtain. The screening test itself might cost the insurance company $150. Fine. But if that screening triggers the cascade, follow-up imaging, specialist consultations, biopsies, procedures, the total cost can balloon to $15,000 $30,000, $80,000 for a surgical intervention. And who pays for that? Your insurance premiums go up, your co-pays go up, your out-of-pocket maximums get hit. The screening was free. Everything it triggered was not. And here's the part that really stings. Your insurance company knows these numbers. They have actuaries who calculate exactly how often a screening test leads to a cascade and what that cascade costs on average. But the medical billing system is built to reward volume. More tests ordered, more procedures performed, more referrals made. Every step in the cascade generates a billing code. Every billing code generates revenue. Nobody in this chain is rewarded for saying, actually, let's not test. Let's watch. Let's wait. I'm not saying there's a conspiracy. I'm saying there's a financial architecture that incentivizes overtesting. And you, the patient, are the one who bears the physical risk of that architecture. Okay, let me get back to the list. Because this next one, when I saw the overdiagnosis data, I had to read the paper 3 times. The thyroid. That butterfly-shaped gland in your neck that controls your metabolism, your energy, your weight, your heart rate. Obviously important. And thyroid ultrasound? Useful tool. If you have a lump in your neck, if your thyroid blood work comes back abnormal, if your doctor feels something during a physical exam. In those cases, absolutely, get the ultrasound, no argument. But routine screening? In people who feel fine? With normal thyroid function? The USPSTF has recommended against it since 1996. That's almost 30 years of the same recommendation. And the data supporting that recommendation has only gotten stronger. Here's why. If you take a random healthy adult, no symptoms, normal labs, and scan their thyroid with ultrasound, you will find nodules in up to 60% of them. 60%. More than half of everyone walking around right now has thyroid nodules they don't know about. The overwhelming majority, completely benign, harmless, would never cause a single symptom for the rest of their lives. They're just there, like freckles on an organ. But once the ultrasound finds them, you know what's coming. The cascade. Follow-up imaging. Then a fine needle aspiration biopsy, a needle inserted into your neck to extract cells. Then the pathologist looks under the microscope and sees cells that look ambiguous. Not clearly cancerous, not clearly normal. Somewhere in between. And now the conversation shifts to surgery. Thyroidectomy. Removal of part or all of the thyroid gland. That surgery has real consequences. Damage to the recurrent laryngeal nerve, the nerve that controls your voice. Permanent voice changes. I've talked to people who went from singing in their church choir to barely being able to speak above a whisper. Because of a surgery to remove a cancer that was never going to hurt them. Hypoparathyroidism, where your body loses the ability to regulate calcium properly. That means calcium supplements. Every day. For the rest of your life. With monitoring. With blood draws. With the constant risk of calcium levels dropping dangerously low. And once your thyroid is removed, you're on synthetic thyroid hormone. Every morning. Forever. With dose adjustments. With lab monitoring. With the fatigue and weight fluctuations that come when the dose isn't quite right. All of this. For a cancer that was never going to cause harm. And I'm not speculating. A landmark paper published in the New England Journal of Medicine laid it out. In the United States, overdiagnosis of thyroid cancer, meaning the detection of tumors that would never have caused symptoms or death, accounted for 70 to 80% of thyroid cancer diagnoses in women, and 45% in men. Let that land. 7 to 8 out of every 10 thyroid cancers found in women were overdiagnosed. They were real under the microscope, but they were never going to spread, never going to shrink anyone's life by a single day. And here's the proof. Thyroid cancer incidence in the U.S. has tripled over the past 3 decades. Tripled. 3 times as many people being diagnosed. But thyroid cancer death rates? Flat. Almost unchanged. If we were catching dangerous cancers earlier and saving lives, death rates would have dropped. They didn't. We're finding more cancer and treating more cancer without saving a single additional life. We're just putting more people through surgery and radiation and lifelong medication for tumors that were never a threat. A JAMA Network Open study from 2025 confirmed it. Even after adjusting for any real increase in incidence, overdiagnosis remains, their word, substantially high. And the researchers identified widespread thyroid ultrasound as the primary driver. 3 separate expert bodies agree: the USPSTF, the American Thyroid Association, the European Thyroid Association, all saying the same thing: do not screen asymptomatic adults. It causes more harm than good. If a nodule is found by accident, on a CT scan for something else, or during a carotid ultrasound, do not panic. Most nodules under 1 centimeter need 0 follow-up. Ask your doctor about a system called TIRADS. It helps determine which nodules actually need a biopsy and which ones can be safely monitored. It's a risk stratification tool, and it could save you from an unnecessary surgery. Okay, we've reached the last one, and I'll be honest with you. This is the one I spent the most time thinking about how to present, because it's personal for a lot of men watching right now, and the consequences of getting it wrong, in either direction, are severe. The PSA test. Prostate-specific antigen. Simple blood draw. Your doctor checks a number. If it's elevated, you're told you might have prostate cancer. And the dominoes start falling. For men aged 55 to 69, the USPSTF calls this a personal decision. A conversation between you and your doctor about benefits and harms. And that's fair. There's a real discussion to be had in that age range. But for men 70 and older? Derecommendation. The USPSTF recommends against PSA-based screening for prostate cancer in men 70 years and older. Published in JAMA, 2018. Based on 3 large randomized controlled trials involving more than 600,000 men. 600,000 men! This is not a small study, this is not fringe science, and the finding is clear. In men over 70, PSA screening shows no reduction in the chance of dying from prostate cancer. None. But the harms? The harms are where this story turns dark. An elevated PSA leads to a prostate biopsy. And a prostate biopsy is not a gentle test. A needle is inserted through the rectum into the prostate gland. Multiple times. Usually 12 separate samples. Risks. Bleeding. Infection. Sometimes serious enough for hospitalization. In rare cases, sepsis. A blood infection that can be life-threatening. And here's what the biopsy often finds. Prostate cancer. Low grade. Slow growing. The kind that, and this is a phrase you'll hear from urologists who are being honest with their patients, a man is far more likely to die with than die from. But once the word cancer appears in a medical chart, treatment begins. And this is where I need you to really pay attention. Because what I'm about to describe happens to real men. Healthy men. Active men. Men who are living full, independent lives. 1 in 5 men who undergo radical prostatectomy, surgical removal of the prostate, develop permanent urinary incontinence. Permanent. That means pads. Every day. For the rest of their lives. 2 out of 3 men experience permanent erectile dysfunction after surgery. More than half of men who receive radiation therapy develop long-term sexual dysfunction. 1 in 6 experience chronic bowel problems. Urgency. Fecal incontinence. Those numbers are from the USPSTF's own evidence review. The United States government. And the overdiagnosis rate? The rate at which PSA screening finds cancers that would never have caused harm? Between 16% and 50%, depending on the study. Up to half. Up to half of the prostate cancers detected by PSA screening in older men would never have caused a symptom, would never have spread, would never have shortened their life by a single day. But because of a blood test, these men, walking, golfing, playing with grandkids, living independently, ended up incontinent, ended up impotent, ended up wearing diapers, for a cancer that was never going to hurt them. Let me tell you about Gerald now. Because Gerald, the man from the beginning of this video, his story was about this test. Gerald's elevated PSA was 5.2, slightly above the 4.0 threshold. His doctor ordered a biopsy. The biopsy found Gleason 6 prostate cancer, the lowest grade. Slow growing, unlikely to spread. But Gerald heard cancer. His family heard cancer. And the urologist recommended surgery. Let's get it out. The surgery damaged the nerves controlling Gerald's bladder. 8 months later, Gerald wears pads. He doesn't walk his 2 miles anymore. His wife says he's a different person. Gerald's cancer was never going to kill him. The treatment did what the disease never would have. And I'm not telling you this to frighten men away from their doctors. I'm telling you because every man over 70 deserves to hear those numbers before the blood is drawn, not after. For men 55 to 69, have the conversation. The USPSTF says this is a shared decision. Weigh the benefits, weigh the harms. If you have a family history of aggressive prostate cancer, or if you're African American, which carries a higher risk, the calculus shifts. Talk to a urologist specifically, not just your GP. But for men over 70? Before your doctor orders that PSA, ask one question. If this number comes back elevated, what exactly will happen next? And what are the physical consequences of each step in that chain? If your doctor can't answer that clearly, the test probably isn't worth doing. I know what some of you are thinking right now. Should I just stop going to the doctor? No, please. That is not the takeaway from this video. Some medical tests after 60 are non-negotiable, life-saving, backed by strong evidence that finding the problem early leads to treatment that actually changes outcomes. Here are the 4. Blood pressure. Every visit, no exceptions. Hypertension is called the silent killer for a reason. No symptoms until the stroke or heart attack hits. It's the single most modifiable risk factor for cardiovascular death. Simple. Painless. Takes 60 seconds. There is no version of "I'm too old for this test." Get it checked. Diabetes and pre-diabetes screening. Fasting glucose. HbA1c. These tests catch blood sugar problems years before they become dangerous. And unlike several of the tests on my list today, early detection of diabetes actually changes outcomes. Diet, exercise, and sometimes medication can prevent or delay the progression to type 2 diabetes. This is a test where finding it early genuinely matters. Colorectal cancer screening between 45 and 75. I just explained why routine colonoscopy after 75 has diminishing returns. But between 45 and 75, it's one of the most effective cancer screenings we have. Polyps found and removed before they become cancerous. That is real prevention. If you're in that range and you haven't been screened, please talk to your doctor. Bone density screening for women 65 and older. The USPSTF gives this a B recommendation. Osteoporosis is silent, just like hypertension. And a hip fracture after 65 can cascade into loss of independence, surgery, long recovery, and sometimes never recovering at all. A simple DEXA scan identifies it early. Treatment exists. It reduces fracture risk significantly. The difference between these 4 and the 5 I covered today? These 4 have strong evidence that finding the problem early leads to treatment that actually improves how long and how well you live. The 5 on my list? Finding the problem early often leads to treatment that causes harm without improving outcomes. That is the line. And knowing where it falls is your right as a patient. Okay, so 5 tests. A lot of information. And I know it can feel overwhelming. So let me give you something simple. Something tangible. Something you can literally write down on an index card and bring to your next doctor's appointment. I call it the preparation card. 3 questions. That's it. Question 1. What changes in my treatment if this test comes back abnormal? This is the most important question you will ever ask a doctor. Because if the answer is nothing, if you'd be managed the same way regardless of the result, then why are you taking on the risk of the test? You're exposing yourself to the cascade for no clinical benefit. Question 2. What are the possible harms of follow-up procedures if something is found? Every test has downstream consequences. A positive screening leads to more tests. Those tests have risks. You deserve to understand the full chain, not just step 1, before it starts. Question 3. Given my age and my health conditions, is the benefit of this test likely to be realized within my expected lifespan? This is the hard question. The one most doctors won't bring up on their own. But it's the most important one for anyone over 70. If a screening test catches something slow-growing that takes 15 years to become dangerous, and you're 78 with heart disease and diabetes, that screening isn't protecting you. It's exposing you to risk without realistic benefit. Write those 3 questions on a card. Bring it to